Welcome to ATCM, the Emergency Medicine Channel. A 50-year-old male patient came to our ER with a complaint of bilateral knee pain since 5 days. On initial 10-second assessment, patient was conscious and oriented. Primary survey, airway was per patent, no C-spine tenderness, C-spine appears normal. Breathing part, iron bilateral equal, respiratory rate is 20 breath per minute and saturation was 98 on room air. Coming to circulation, BP was 160 per 100 and pulse rate is 81 per minute. On disability was GCS, E4, V5, M6 and people's bilateral reactive. And patient complained of pain over bilateral knee, right more than left. The SSA pain score is 7/10. So we give.
Just you tell me what is the importance of C-spine in a rheumatological case, arthritis case?
Initially, patient came with complaint of.
That's okay. I am not asking. What is the importance of C-spine in a rheumatological case?
Cervical spondylosis.
Which all conditions?
Cervical.
Cervical spondylosis. You want to tell cervical spondylosis?
Arthritis causing.
Which arthritis cause cervical disease?
Ankylosing spondylitis.
Ankylosing spondylitis, which part of the spine will be involved?
Mostly
LS spine is.
Very rarely C-spine may be involved, but is there any involvement of C-spine in rheumatoid arthritis?
C7.
What is involvement? Subluxations are very common in rheumatoid arthritis. Not complete dislocation, subluxation. That means there is a chance of dislocation when you are handling the C-spine in rheumatoid arthritis. It is not well known that cervical spine is directly involved in rheumatoid arthritis, but there is a high chance of cervical subluxations. So you have to be very careful when you are handling rheumatoid arthritis. Like you told, ankylosing spondylitis, there is a possibility of involvement of whole spine.
Disability part, patient complaint of bilateral knee pain, right more than left, and the pain score it is 7/10. So we given a pain to relieve pain, given injection PCM 1 gram IV. We can given. Next exposure part.
What is pain ladder?
It's a WHO pain ladder. We can assess the patient pain and we can give initially lower dose of medication like paracetamol. Then we can go into NSAIDs. Then we can go into weaker opioids, stronger opioids.
Okay. They're basically designed for what type of pain? Pain ladder by WHO is designed for what type of pain? Later it was involved in all types of pains. What is the type? Malignancy. It is basically designed for malignancy, but nowadays we can use the same pain ladder for all the conditions, including rheumatoid diseases.
Exposure what temperature was normal. GRBS is 119 milligram deciliter. Then we go to investigation like point of care. In our point of care, we send CBC CRP.
What are the joint examination you have done in this patient?
Yes, sir. On examination, local examination, on examination of both knee, on inspection wise, there is no any fullness, there is no any redness, there is no any deformity like shortening of leg. Then on palpation, there is local rise of temperature, tenderness was present, moreover the lateral side of the knee, and there is no any neurovascular deficit. Then range of movement is restricted due to pain.
Okay.
He is not able to flex his knee. Then system-wise examination.
What is the difference between active movements and passive movements in joint examination?
Passive movement, active movement is by an external person is doing the
active movement
is when the patient is moving. Passive movement is done by the external. So in active movements, is pain is there, and it is because of intra-articular.
Active movement, if there is pain, that is possibly an extra-articular area like muscles, tendons, all this thing. if pain is already there on passive movements also, like we are examining, we are moving the joint, that time pain is there, then there is a high chance of joint involvement. So that you have to do both active and passive.
All other system wise it is normal limits. Then history wise, ambular history. 50-year-old male patient came to our ER with a complaint of bilateral knee pain since 5 days, which is right more than left. Then followed by patient was not able to walk by himself. He's become then this is a known case of non-Hodgkin's lymphoma on 2008, followed by developed drug-induced cardiomyopathy. Patient was on carvedilol, clonidipine, ivabradine, digoxin, and torsemide. Patient had an history of pain over his left foot 2 weeks back. For this, he checked his serum uric acid level showing 10.7. Then he started on tab allopurinol 300 mg OD for 5 days.
When there is a asymmetrical large joint involved, there are some more history is required. One is if the patient is having any spine involvement, like ankylosing spondylitis histories, we have to rule out. Second thing is you have to ask any bowel involvement. Like bowel diseases can also sometimes present with peripheral large joint asymmetrical arthritis. Okay, so that also we have to rule out. We have to ask about urinary tract infections, eye involvement,
Seronegative arthritis.
All these things we have to rule out. When you are taking history, you have to just ask whether any back pain is there, any like cervical pain is there, eye involvement is there, urinary tract infection is there, or any stool, like altered stool, abdominal pain, blood in the stool. All these things we have to ask.
Negative history, no history of fever, trauma, other joint involvement, no history of diurnal variation, no history of any bowel or bladder incontinence. So history wise and clinical wise, we are suspecting this patient has gout. Then we send the routine investigation, routine CBC, CRP, LFT, RFT, serum uric acid levels. Then total counts coming to it is 12,800. CRP was 96.34. Our serum uric acid is 4.5.
You think it is gout and uric acid is only 4? How will you explain that? What are the ways you can explain this?
One explanation is initially 2 weeks back patient has uric acid 10.7. Then from outside they started on tab allopurinol. So it will also
can reduce it. That is one reason.
And in some acute gout flare-up, sometimes serum uric acid will be normal.
Why?
Because the uric acid will deposit in the joints.
Okay. So there are two possibilities. One is already treated, partially treated. Other one is can be deposition.
And RFT is sent. RFT is showing creatinine is 0.7 and urea is 29.5.
Okay. What are the ways kidneys can be involved in uric acid?
On hyperuricemia.
Hyperuricemia can involve kidneys. What are the ways kidneys can be involved? Calculate. Commonest is calculate. Then one is uric acid nephropathy. Uric acid itself can produce crystal nephropathy or non-crystal nephropathy and obstruct the smaller canaliculae in the nephrons in the kidney. That itself can produce renal failure. So uric acid can produce renal stones and obstruction. Inside kidney itself it can create problem and creatinine can be involved. Can renal failure can produce high uric acid?
Yes, sir. It can also cause hyperuricemia.
What is the mechanism?
Because uric acid is reabsorbed from the renal tubules. So in renal failure also cause hyperuricemia. A secretion of the uric acid. So it was
excretion of uric acid is normally done by kidneys. If kidneys are failed, you can get high uric acid.
Then we aspirate there is effusion is there. We've done a USG showing bilateral knee effusion, right more than left, 18 mm effusion. So we aspirate the effusion, we send for metrology, biochemistry, microbiology. It's showing positive biofilm needle-shaped crystals in the uric acid.
Okay.
So we come to a diagnosis of acute gout. Then we started on treatment. Treatment initially started on colchicine.
What is the treatment according to any rheumatological disease? How do you treat acute arthritis?
NSAIDs.
First is what?
Steroids,
First.
painkiller, and
First one. What is the first treatment you advise to the patient?
Rest.
Complete rest is the most important thing because any acute inflammation of joint, acute rest of that joint is very, very important. So, how do you achieve that in this patient?
Uh,
How do you achieve rest for knee joint? That is very important. Bandage. You have to immobilize the limb. Best way is to put a crepe bandage and restrict the movement of the knee joint, because he'll be like unknowingly when he's on bed, he'll be moving his legs. So here you have to completely immobilize that joint. Then only recovery will be fast. Okay. So immobilize the joint first. Then then only rest all comes. Then pain management. How do you manage the pain? Already we had discussed. Paracetamol.
NSAIDs we can use. Then we can use colchicine. Colchicine.
What is the dose of colchicine?
Day 1 dose it is 0.2 milligram of at the first sign of flare up. Then we start on 0.6 milligram every 1 hourly up to a maximum dose of 3 milligram. Then day 2.
What are the side effects of colchicine?
Gastroenteritis like vomiting, diarrhea.
Gastritis. Okay.
These are the side effects. If this happen, we can stop the colchicine.
Okay.
On day 2, thereafter the day 2 start on 0.6 milligram once or twice daily until the flare up.
Colchicine is available in 0.6 or 0.5?
0.5 available is 0.5
0.5.
milligram.
Okay.
Then day 2 0.6 milligram once or twice daily up to the flare resolves. Then we can start on, if pain was not decreasing, we can start on one is if effusion is there, we can give intra-articular glucocorticoid,
Okay.
or we can give IV glucocorticoid. The IV dose is methylprednisolone 20 milligram IV we can give.
What is the difference between normal methylprednisolone and intra-articular methylprednisolone? Same thing we are giving? We are not giving the same methylprednisolone what is given for asthma. It is different. What is that preparation? You are giving same drug. No, you cannot give. It's a depot preparation. Slow release depot preparations are available, 40 milligram. So that has to be given to intra-articular, not the routine thing what you are using for your asthma. Both are different. Okay. So that has to be given. Then
When intra-articular triamcinolone also we can use.
okay. Then can we give IV steroids in this patient?
IV steroids we can
Can we
use.
give? If inflammation is too much, pain is too much, better to start steroids as IV, so that it will give a faster relief for the patient. Okay. Then
That is methylprednisolone 20 milligram IV BD daily we can give up to
BD. BD. Methylprednisolone is given as BD or OD? Why? Where will you give BD? So many times we have discussed this. Where will you give methylprednisolone as a BD dose? Where will you give it as OD dose? If you give BD dose, what will happen? These things are very important. These are the common mistakes done. So normally anti-inflammatory dose, whatever dose you want to give, it has to be given OD only. When you are giving a replacement dose, like a patient is having adrenaline insufficiency, you give TID, QID, BD, at least minimum is BD. Okay, but in sepsis we give 4 times daily. Okay. Otherwise, what will happen? Like you told, if you are giving a evening dose, that will stop your adrenaline release. Okay, steroid release from the pituitary gland. Okay, so we have to avoid that. So only once daily dose, that too morning dose, is the best steroid dose. Whatever you want to give, maximum dose can be given as a single dose. BD dose should be given only in replacement conditions. Okay, so steroid can be given. Don't again tell, don't like BD or TID. That should be given only in specific conditions. Then role of fluids in
Fluids you can to wash out the uric acid. We can
short means
to excrete the uric acid through kidney. We
anyway
can
it will
use.
go on. What is the role of fluids in high patients who is having gout? When your uric acid is very high, where it will go? It will go either to your joints or it will go to kidneys. From kidney it will go through the urine. Suppose your urine output is low, you are not taking water. What will happen?
Deposit, calculate.
It will deposit in the kidneys. Okay, it will produce uric acid nephropathy, urate nephropathy, or uric acid stones. All complications can arise if you don't take adequate water. So better to give IV fluids or ask the patient to take a lot of water. That is a must. That's why during summer seasons, especially Gulf countries, uric acid stones are very high. Okay, they are not taking water. Okay. So IV fluids or oral fluids are have to be given. Okay. Then, so you have started colchicine first. Then you have given pain relief medication. Then you have given steroids if required. IV fluids are given. Next is what?
Rest.
What is this colchicine? What is the action of colchicine?
Anti-inflammatory.
It is only an anti-inflammatory drug. It is not anti-gout drug. It is only anti-inflammatory. Something like paracetamol, NSAID, steroid, colchicine. Colchicine can be used in various other conditions also. Okay.
Can use in.
So next what do you do?
Preventive drugs we can use.
So now you have to start preventive drugs, febuxostat or whatever he was taking some other. Allopurinol. So the commonest mistake done in all cases, allopurinol is started as a high dose during the first phase. That is not correct. You have to reduce the inflammation, then only you should start preventive drugs. Okay. So allopurinol or febuxostat. What is the dose of febuxostat?
40, 80 and 120 mg is available. We will start initially 40 mg.
Allopurinol?
Allopurinol 100 mg.
100 mg, 200 mg, 300 mg. What is the problem of allopurinol? Why it was not used nowadays? Why?
Allopurinol causes hepatic and kidney.
Okay. When you are using it, you should follow up the patient with the LFT and creatinine. Second thing.
Other causes drug interactions.
So there are a lot of drug interactions when the patient is taking allopurinol. We have to check the drugs and start newer drugs. Okay. So that was a limitation for allopurinol, but febuxostat, that type of side effects are less. Okay. What are the newer drugs for that?
We can use uric drugs like probenecid.
Okay.
Raspberry
is a newer drug, but it is not used in ordinary gout. It is used in
tumor lysis syndrome.
Where there is very high uric acid levels. That can be used. Okay. Anything else you want to add? Nothing. Okay. So this patient already follow up then?
We will give advice to his diet because he had a history of alcohol
diet
intake.
Is very important. What diet advice you give?
To avoid alcohol, beverages like carbonated beverages, high protein diet like red meat, then pulses, cereals, alcohol, especially beer.
Alcohol, beverages, all beverages should be avoided.
Bakery
items, red meat. Okay. What can be taken, what can be advised for the patient? What all things can be advised? Diet.
No protein.
Low protein.
High carbohydrate diet is advised here. High protein, especially meat proteins, are contraindicated in the.
Especially red meat and shellfish.
Okay. That all things should be avoided. Okay. Can he walk after discharge?
Yes.
Okay. So once the pain is over, patient can start walking.
After aspiration, patient pain is
subsided. Okay. Anything else to be added? Okay. Thank you.